Good morning, everyone. My name is Robert Hersey. Happy Thursday to each of you, and on behalf of FATA, welcome to today's webinar titled Alzheimer's Disease and Other Dementias, Differential Diagnosis and Communication Strategies. This webinar is being made available through a collaboration between the Florida Department of Children and Families and FATA. Please note that as an attendee, you are in listen-only mode and are only able to view your name. Your webcam and microphone have been disabled. If you have questions, please send them using the chat panel. We will answer questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio at any time during today's presentation, there are a few options to try using the audio connection panel. For computer audio, click the up arrow next to Audio Settings, click Leave Computer Audio, click Join Audio, then click Join with Computer Audio and follow the instructions. If you continue to experience poor audio through your computer, try calling into the presentation. Instructions are on your screen and will be posted in the chat panel momentarily. You must be connected to the audio of this presentation and view it on screen to receive a certificate of attendance. We cannot verify attendance if you are not connected to Zoom through the website, desktop application, or mobile application. Therefore, phone call only attendees are not eligible for a certificate of attendance or CEUs. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording in PowerPoint, visit www.fata.org, navigate to the Resource Center, and click on Training Library as shown on the screen. A certificate of attendance and CEUs for up to 2 continuing education credits are available for participating in today's webinar. CEUs are available for individuals licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling, and for those credentialed through the Florida Certification Board. To receive a certificate of attendance and CEUs, you must attend the entire webinar. Zoom provides a report of the arrival and departure times of attendees. We are not permitted to provide partial credit. You must also complete the post-webinar survey. The survey will close on Tuesday, November 25th, 2025. Certificates of attendance will be distributed within 30 business days after the evaluation closes. CEUs will be reported to CE Broker for Florida licensed healthcare practitioners within the same time frame. FATA has implemented operational changes to our webinars based on the feedback of our attendees. Below are a few important changes. Evaluations will now take place in Zoom immediately after the webinar. Certificates will now be emailed to you directly using the email address you used to register for today's webinar. You no longer need to sign into your FATA account to complete evaluations. For all webinars and workshops November 2025 and later, certificates will be emailed to you directly. For all webinars and workshops before November 2025, certificates are still available through your FATA account. There is no change to the CEU reporting process. For Florida licensed healthcare practitioners, CEUs will be reported to CE Broker within 30 business days after the webinar. Individuals certified through the Florida Certification Board or licensed outside the state of Florida may use their certificate of attendance for self-reporting. This presentation is intended solely for educational purposes. The views, opinions, information, and content expressed in the presentation are those of the presenter and do not necessarily reflect the views, opinions, or policies of the state of Florida, the Florida Department of Children and Families, FATA, or the Florida Behavioral Health Association. Attendees should note that sessions are recorded and published in various media. Our presenter today will be Dr. Amanda Smith. Dr. Smith is a director of clinical research at the USF Health Burr Alzheimer's Institute and a professor of psychiatry and behavioral neurosciences at the University of South Florida Morsani College of Medicine. She received her undergraduate degree from Emory University and her medical degree from Sidney Kimmel Medical College of Thomas Jefferson University. She completed her residency in psychiatry and fellowship in geriatric psychiatry at USF. Dr. Smith is a diplomate of the American Board of Psychiatry and Neurology with subspecialty certification in geriatric psychiatry. For over 20 years, her work has focused on the diagnosis and treatment of memory disorders, clinical trials in Alzheimer's disease, and education of both caregivers and health professionals. She has acted as a site principal investigator on over 50 dementia treatment studies and has served at the state and national level to advance clinical research in Alzheimer's disease and related disorders. And now I'd like to welcome our presenter, Dr. Smith. Dr. Smith, I will turn it over to you.
Thank you, Robert, and thank you everyone for being here this morning. Just a little housekeeping, feel free to put questions in the chat. We're going to kind of save the questions till the end, and Robert will be keeping track of them. The reason is oftentimes people will ask questions about things I'm going to cover a little bit later. So in the interest of time, because we have a lot of ground to cover, we're going to do it that way, but we will get to your questions, I promise. So these are today's learning objectives. We're going to talk about several different types of dementia and their key features. I'm going to talk about tools available to clinically diagnose Alzheimer's disease because we've made a lot of progress in the last several years in that regard. And then the last part of the session will be talking about various techniques for communication when you're talking to people with dementia. These are my disclosures. Just to point out, we receive research funding for clinical trials. That's how new drugs come to the market. This is money that goes to our team and to the university and not directly to me. So the first part of the talk is going to be sort of going through different types of dementia. Dementia, starting with the basics, is an umbrella term that just really describes having changes in memory and thinking. It's acquired, meaning that it's not present from birth, and they're severe enough to interfere with your day-to-day life. So a lot of people tend to sort of mislabel Alzheimer's or think Alzheimer's is sort of a later stage of dementia or the worst stage of dementia. That's not true at all. Alzheimer's is one cause of dementia, of which there are many. And Alzheimer's actually has, a whole spectrum of stages, some of which, in the early ones, you don't even know you have it. So I'll talk about that in a little bit. But regardless, dementia is more common as we get older, and age is actually the biggest risk factor for almost every type of dementia. So Alzheimer's disease is the most common cause of dementia. It accounts for at least half of all cases. Currently, it affects over 7 million people in the United States. About 10% of people over 65 have it. That you're talking about all people over 65, and up to 35% of people at 85. So again, age is the biggest risk factor. Up to half of people 85 and above have some kind of dementia. And a lot of people actually have mixed pictures. So, somebody could have both Parkinson's and Alzheimer's, or vascular disease and Alzheimer's. And so they're not mutually exclusive. Usually these are, neurodegenerative processes that start with mild symptoms and progress from, forgetfulness to total disability. And Alzheimer's specifically, and what makes it unique and Alzheimer's, is that it's characterized by the buildup of abnormal proteins in the brain. So there's plaques made of amyloid, and then there are tangles made of tau. The plaques are kind of outside the neurons, and the tau tangles are inside the neurons, and they start in the brain many, many years before symptoms appear. So 95% of cases of Alzheimer's disease are what we call late onset. People sometimes mix up early stage or late stage with early onset and late onset. So when we're talking about onset, we're talking about the age at which you get the disease. So 95% of cases are late onset, people, above age 60. And it's, considered a consequence of aging. About 5% of cases are considered early onset. These are people that get it in their 40s and early 50s. This is often and almost always due to three very specific gene mutations in your DNA that are dominant. And this kind of Alzheimer's tends to progress more rapidly. The time from diagnosis to death is often a little bit shorter than it is in older people. And they more often have seizures later in the disease and more visuospatial difficulties. Um, so last year, there was a paper that came out that sort of redefined the staging of Alzheimer's disease based on the biological changes that I mentioned, those plaques and tangles. And, you know, when I started out in this field, Alzheimer's was considered like the stage of Alzheimer's was considered dementia. And it wasn't until 2011 that the first idea that Alzheimer's exists in the brain years before symptoms appear was really kind of accepted by the FDA and accepted as a continuum. Just like heart disease is a continuum, if you think about it, you know, you don't say someone has heart disease only when they have a heart attack or a stroke, right? So there's years of building up cholesterol plaques in their vessels around their heart. So Alzheimer's now has a similar sort of staging system where the pathology is starting to build up, but then eventually symptoms appear. So stage 0 is actually someone who has absolutely no symptoms. They have no idea anything's wrong, but this might be an early onset person whose mother had early onset Alzheimer's disease and they have inherited that dominant gene from them. They're gonna get Alzheimer's. So if you are the child of someone with early onset Alzheimer's disease and you inherited that same gene, you will get it because it's dominant. So someone like that would be stage 0. Fortunately, there aren't that many people walking around like that. Someone in stage 1 is, someone who's starting to build up amyloid in their brain, doesn't yet have any symptoms, and may be totally unaware that anything's happening. Stage 2 is when maybe there starts to be the very first signals that something is wrong. Stage 3, there is some cognitive impairment, but people from the day-to-day functional standpoint can still take care of themselves, their activities of daily living are intact, etc. It's not until we get to stage 4 that someone actually has dementia. So there are all these stages of Alzheimer's before you get to dementia. And what the crux of the key difference between MCI, mild cognitive impairment, and dementia would be that there is functional change. Someone who was taking care of their bills is now making mistakes and their wife had to take it over. Somebody who was, cooking with no problem from memory now kind of has to go back and forth to a recipe and makes mistakes and skips steps. So that means there's now functional impairment. And then, the subsequent stages have increasing, moderate, and then severe functional impairment, whereas stage 6 is someone who is total care, fully dependent on others for ADLs and IADLs. I did see a question pop up about, what would be something in stage 2. It's those early subtle changes that, something's not quite right, but you can't really pinpoint that something's wrong either. There's just slight changes in, maybe struggling the littlest bit, or, maybe asking your loved one something twice and then remembering it, rather than once. Little tiny things. As the questions are relevant, I'll answer them, but a lot of the other ones will wait till the end. The cutoff is debatable depending on your source. It's that 60 to 65 window. But people who get dementia, who get Alzheimer's at 60 aren't really considered early onset because the initiation of symptoms really is in the 40s and early 50s for true early onset. There are people that have sort of indeterminate onset, they're not officially late, but they're generally speaking, from a pathologic standpoint, statistically, they fall into the late onset. So, it's a little bit a matter of semantics, but at the end of the day, most people that are in that 60 to 65 window from a pathologic standpoint lack the genetic biomarkers of early onset and really are late, even if other places will say it's 65. So some of the tools that we have for diagnosis of dementia have really advanced in the last few years. However, one key component remains the clinical interview with a patient and someone who is close with them. A lot of times people are fully aware of what's going on with them and, recognize something's wrong and request an evaluation, but sometimes people are blissfully unaware that anything's wrong. And so having a family member who can report on what changes they've noticed is often extremely helpful because, there's often a discrepancy between what the patient sees and feels and what the person around them, an observer sees. So ideally, when we see patients for the first time, we always ask them to bring a loved one to provide collateral information. And sometimes it's exactly the same, and sometimes it's very different. When I ask the patient, what brought you in today? The answer is, he did, and I don't know why I'm here. So it's helpful to have an informant. And that remains a very, key rich part of this, because understanding exactly what deficits they have, what they still do well, is important in helping tease out that diagnosis, and also in terms of staging. Cognitive testing obviously is very helpful in the clinical setting. We usually use an MMSE or MoCA, but there are times when we do formal neuropsych testing because the diagnosis is unclear or people have sort of a murky picture. We do labs to rule out reversible causes of dementia, things like thyroid dysfunction, vitamin deficiencies. We do structural brain imaging. MRI is preferable, but if someone can't have an MRI, CT can be adequate. Really looking for structural brain changes, shrinking in the hippocampus or the temporal lobes, which can support Alzheimer's. And we also look at assessing the amount of vascular disease. FDG PET is a type of PET scan that looks at brain activity. People are given radioactive sugar, and then that kind of has a chance to circulate, and then you take a picture of how active the brain is. And there are classic patterns in the different types of dementia that can support one diagnosis over another. In FDG PET, the temporal and parietal lobes are less active, whereas, for example, in Lewy body dementia, which I'll talk about a little bit later, the occipital lobe, or the back of the brain, is less active. In frontotemporal brain disease, the front part of the brain is less active. So that can be helpful when things are not clear. So more recently, we've had the advent of imaging biomarkers specifically for the plaques and tangles. Amyloid PET is fully available clinically now, covered by insurance, and so you can actually get a PET scan that shows that amyloid plaque in the brain. This is, has really kind of revolutionized our field because we're able to really see that plaque and tell people for sure whether they have Alzheimer's or not. Tau PET, which images the tangles, is also technically FDA approved, but because of cost limitations on when they make the tracer and lack of insurance coverage, it's not something that we can order for everybody at this point in time. However, whereas amyloid starts to build up years before symptoms begin and is sort of fully present at the very beginning of symptoms, tau actually kind of increases in direct correlation with the degree of symptoms and the way that it spreads. And so it's actually a better way for staging from a research standpoint, but we're not quite there clinically to be able to use that. We hope to get there, eventually, but it is at least been invented and is available and is on its way. It's just kind of lagging behind the amyloid PET by several years in terms of its availability and coverage. An area where there's been wonderful advances in the last few years has been in blood biomarkers. We can now order a simple blood test that's quite accurate in the 90 plus percent range, like 92% positive, true positive, 97%, for negatives, that really confirm whether Alzheimer's is present and correlates about 97% to amyloid PET. So we can, people can come in and we can order a blood test as a starting point. And if those blood tests are positive, then we can go on to get confirmation with amyloid PET. But the blood tests really have made our field just explode in terms of being able to give people an accurate diagnosis. One issue that has come up, you'll go back to that staging system. We do have people that are totally normal that have gone to their primary doctor and said, hey, can you order me this test? My mom had Alzheimer's. And then they get the blood test and it's positive. So these are people that would fall under that stage 1, asymptomatic, but positive biomarker. And we're not in a position to really be able to treat people like that yet. So at the moment, the guidelines are not to go looking for something that doesn't yet, have the ability to be treated. But, we are hoping, we are involved currently in some prevention trials. So for people exactly in that boat who are receiving some of the newer drugs that are available to target and remove plaque in the hopes that they will not then progress to go on to have memory issues. And if those trials are positive, then we may actually have an indication to do this kind of preventive medicine with blood biomarkers. But in any case, the blood biomarkers are now available and very, very helpful in terms of determining whether someone has Alzheimer's or not. The spinal fluid analysis is another one. Both the blood biomarkers and the spinal fluid analysis are looking at the amyloid ratio, amyloid beta 42/40, and the amount of p-tau 217. And then p-tau 181. So phosphorylated tau and amyloid. And then the most recent FDA approved test, which is the LumiPulse test, that's actually considered diagnostic as opposed to just considered risk related, is actually looking at the ratio of p-tau 217 to amyloid beta 42. And so that's the main blood biomarker. And that's also what they're looking at in the spinal fluid. Genetic risk factors can be helpful. With late onset Alzheimer's disease, there's not specific mutations like there are with early onset, but there are, in particular, the ApoE genotype. So ApoE is a gene that codes for a protein that carries cholesterol around in our blood, oddly enough. But you can have ApoE2, ApoE3, and ApoE4. And you get one from mom and one from dad. People who carry E4, and more specifically, people who have 2 copies of E4, have higher rates of Alzheimer's disease, may get it a couple years earlier, may progress a little bit faster. You can have 2 copies of E4 and never get Alzheimer's, and you can have 0 copies, or you can have E3 and definitely get Alzheimer's disease. So it in and itself does not cause the disease. It just kind of increases risk and somewhat changes response to treatment and stuff like that. They are currently marketing a skin biopsy test, also looking at some of these proteins. We have not used it yet. I don't really know what the cost is, but that's not something that we're currently doing, but it did recently become available as there are similar tests for Parkinson's and Parkinson's related disorders. As far as the treatments for Alzheimer's, I won't get into too much detail, but for years it was just sort of the first bullet that we had. The donepezil, rivastigmine, and galantamine, also known as Aricept, Exelon, and Razidine, are all cholinesterase inhibitors. They help provide acetylcholine in the memory pathway, basically just for those neurons to talk to one another, and can help actually regardless of the cause of memory loss. So some people find they can come up with a word faster or somebody's name. A family member might notice that they ask them the same question 2 times instead of 5 times in an hour. So it's slight benefit. There is sort of a slowing of decline to some extent, and there has been data, for example, showing a 2-year difference in time to nursing home placement in people on these drugs versus people who are not. But they don't actually do anything to the underlying disease. They're not disease modifying. Memantine is also a symptomatic treatment. It acts on the NMDA receptor and helps normalize levels of glutamate. It tends to be more effective in moderate to severe Alzheimer's disease. And often when we give it too early, it can make people feel foggy and more confused. But ultimately, we end up getting people on one of the first three plus memantine if they're able to tolerate it. And that for, literally the last 23 years was all we had. In the last couple of years, these disease modifying therapies have become available. There was another one called aducanumab, which was approved for a period of time, but it had a conditional approval, and there was a lot of drama with the FDA regarding its approval. So ultimately, it's been withdrawn from the market because these other 2 drugs have full approval, but there were 3. So we have lecanemab and donanemab. These are both considered monoclonal antibody therapies. These are given by IV. These target different sort of species of the amyloid protein in the brain and remove it. And in doing so, can slow the progression of Alzheimer's by about 30%. They don't improve memory. They don't cure the disease. They don't make people better. They just sort of dial back the accumulation of amyloid. But people, they don't take away what's ever driving the making of amyloid. And so over time, people will reaccumulate amyloid, and it will also not fix damage to neurons that has already occurred. So there is a bit of, I think people want these to work better than they actually perform, but, it is an advance that took many years and, gives people a little bit more hope in terms of preserving function for longer. These drugs, importantly, can cause brain bleeding and brain swelling as a side effect of treatment, although it's not the same mechanism. Picture a scab, right? And then you pick the scab and you might bleed a little, or you might have some oozing of clear plasma. The same sort of thing happens-ish when you remove the amyloid. So that's why you can get brain bleeding and brain swelling as a consequence of treatment. So we do have to be careful about who we select for that kind of treatment. People who are on, big blood thinners other than aspirin are at risk and not indicated for that. People who have 2 copies of the E4 gene have significantly higher risk. So we do have to check that and be careful about who we select. It's important to also note that there are a number and a growing body of data supporting non-pharmacologic treatments and lifestyle interventions for Alzheimer's. Things like exercise, dietary changes, and a Mediterranean type diet, with lean proteins, not a lot of fats, not a lot of fried foods, naturally colorful foods, and fruits and vegetables can be, especially in combination with exercise, can be super important. And in fact, there was a study called the US Pointer Study, the results of which came out last summer, or I guess this past summer in July, um, showing that in people who were kind of sedentary couch potatoes and had a multimodal intervention with diet, exercise, and actually some cognitive training using the Brain HQ software, they actually got better with memory over 2 years. So those lifestyle interventions are actually better than any of these super expensive drugs that we have. So I cannot stress enough how important that piece is to this puzzle. And then finally, as far as treatments, we have symptomatic therapies for mood and behavior and some of the, issues that people develop in conjunction with their dementia, that I'll talk about a little bit later towards the end of the presentation. But targeted therapies, if somebody's depressed or very anxious, they can respond to antidepressants. If they have hallucinations and false beliefs and are paranoid, the antipsychotics can be helpful. If people have a lot of outbursts and anger issues and sometimes physical violence, mood stabilizers like are used for bipolar disorder can be useful. So, we try to start low, go slow, and use, the lowest doses to target specific symptoms. Because obviously, in this population, there are a lot of risks, including falls. And so we want to be careful that we don't add problems to the ones they already have. So that was all about Alzheimer's and diagnosing it and treating it, but there are a number of other dementias out there. This is just a list of some of them, and I'll get into each one individually in a moment. Um, but, there are any number of reasons why people can have dementia besides Alzheimer's disease. And it's important to note that there are some potentially treatable dementias. So, sometimes somebody can present with symptoms that look or feel like Alzheimer's, but at the end of the day, their thyroid's way out of whack, or they have a raging vitamin B12 deficiency. Even they can have depression that looks like dementia. Sometimes it's a side effect of medication, in particular, oxybutynin, that is often prescribed for bladder problems in the elderly, is very, very, very anticholinergic and works in a way that's exactly opposite to donepezil, for example. And so rather than helping increase acetylcholine, you're blocking it completely. And there's, you know, symptoms that look exactly like Alzheimer's, and all you have to do is stop the bladder medicine and then they go back to normal. So, it's very important to look at potentially reversible causes. Hydrocephalus is another one. Normal pressure hydrocephalus, people will present with, well, I'll get to that a little bit later, but they present with symptoms, and a shunt, neurosurgery intervention can actually either cure or completely um, improve a lot of their symptoms. So getting into some of these individual types of different dementias, Lewy body disease is another very common illness. It's often misdiagnosed, but if you look at autopsy statistics, about 20% of people with dementia will actually have Lewy body pathology in their brain. Lewy bodies are these inclusions in the cells. Lewy body kind of falls under the Parkinsonian spectrum. It's a cousin of Parkinson's disease. The main presenting features are people will have an Alzheimer's-like cognitive change. They will have Parkinsonism, not always tremor, but definitely like slow shuffling, maybe decreased blinking, decreased arm swing, things that are typical for Parkinson's. And they very often will have visual hallucinations, seeing things that aren't there. All of these three things tend to occur within 2 years of one another. And when they do, it most often is Lewy body disease. Um, Another very supportive factor is if they do have a preceding history of restless leg syndrome or REM sleep behavior problems, meaning they, act out their dreams physically. A spouse might say, "Oh, he punches me at night because he's in a fight with someone in a dream." That's a red flag that maybe Lewy body disease is either present or brewing. But obviously there are people that have REM sleep behavior problems that never go on to get Lewy body disease. But in the context of someone who is having cognitive impairment, it's important to consider that. Another thing that's extremely important to know about Lewy body disease is that people have extreme antipsychotic sensitivity. So sometimes we find out someone has Lewy body disease because they were hallucinating. They ended up in the hospital for some unrelated issue and they were given Haldol in the hospital for their hallucinations. And all of a sudden they were markedly worse instead of better. That can indicate that Lewy body disease is the diagnosis. In terms of diagnosing Lewy body, I mentioned earlier, FDG PET can be helpful because there's decreased metabolism in the occipital lobe. There are these skin biopsies looking at alpha-synuclein abnormalities that help diagnose Parkinson's and can also help diagnose Lewy body disease. A DAT scan, a dopamine transporter scan that's often used to diagnose Parkinson's, sometimes is positive in Lewy body patients. For these patients, we still use the cholinesterase inhibitors like Aricept and Exelon. They can be useful for the cognitive as well as helping a little bit with the motor symptoms. Oftentimes, carbidopa or Sinemet that's used to treat Parkinson's isn't as helpful in treating the motor symptoms in Lewy body disease as it is in Parkinson's. We really try to avoid antipsychotic drugs whenever possible, although low dose Seroquel, like 25 or 50 milligrams, is sometimes tolerated if someone really needs help managing those hallucinations or paranoia. Vascular dementia is probably, again, right up there with Lewy body in terms of how common it is. It often is present in conjunction with Alzheimer's, but it accounts for about 20% of dementias. You can get vascular dementia from a series of large strokes, a couple of large strokes or a number of small vessel strokes. Oftentimes people will have, if you look at an MRI, it'll have like a lot of little white dots sprinkled all throughout. And it just means that a lot of those connections have been disrupted. Typically, the deterioration with vascular dementia is stepwise. With Alzheimer's disease, it's more of a steady, slow decline. And with vascular disease, it tends to go like this. Each time there's a new stroke or a new, insult, it kind of drops a bit. So it's a little bit more stepwise as far as its deterioration. But that can be more subtle when it is small vessel disease. The key is really stroke prevention and lifestyle changes, preventing future strokes. But there is, again, data showing that the cholinesterase inhibitors like Aricept and Exelon and Razidine can be helpful in terms of symptomatic treatment of some of the memory complaints and also language. People with vascular dementia can, as with Alzheimer's and other things, can get aphasia or trouble coming up with words. And sometimes, at least, this kind of treatment in conjunction with speech therapy can help with some of their language complaints. Alcohol-induced dementia comes from chronic heavy alcohol use. It is felt to be a combination of thiamine deficiency, which is vitamin B1. Chronic use of alcohol strips our ability to absorb B1, as well as the direct toxic effects of alcohol. oftentimes people will have both, forgetfulness, memory deficits, as well as executive dysfunction, um, trouble sort of like completing tasks and doing, figuring out how to do stuff like navigate the TV menu or whatever. And they also frequently make stuff up. That's what confabulation is, a fancy term for making stuff up. They will lie, but they're not really lying intentionally because in their mind they believe it's true. But, they just make things up about their history, about their lives, about their experiences. Sometimes it's grandiose and sometimes it's very, run of the mill, but they will just, usually it's the person that's like, oh, I went to, Korea and I was a four-star general and blah, and the person's spouse is sitting there in the background shaking their head no, because none of it's true. So if you see someone like that, oftentimes alcohol is a factor in their cognitive issues. Um, the good news about alcohol-induced dementia is if they stop drinking, it will not get worse unless they have some other concomitant dementia along with it. But, it rarely improves, but it can stay steady and at the same level. It won't get better, but it won't get worse as long as they don't continue to drink. The frontotemporal dementias have their own umbrella with several kind of different diagnoses and syndromes underneath. Um, One is primary progressive aphasia, which presents primarily with language problems. These are people where you test them, their memory is fine, and they just have trouble talking. Eventually, as years pass, they will start to have cognitive issues. This is actually what Bruce Willis has. And he has sort of gotten into a point where he's apparently, I've not evaluated him myself, has gotten into a point where, now he's having more cognitive issues and needs help with ADLs. But in the beginning and for several years, PPA usually is just a language problem. It's almost like someone had a stroke and can't speak the way they want to. It's usually a fluent type of aphasia, meaning that it's not like they can't say words, they just talk around them. And often, especially in the beginning, the prosody of their speech is normal. But, for example, they might say, if you ask them what they did today, they'd be like, oh, I went there and we did that stuff. And then we went to the other place and did the thing, so there's no detail, but the prosody is normal. Eventually it becomes more stuttering and halting speech and just one word at a time. But again, that's over many years that occurs. Um, the more sort of prominent and problematic type of FTD is behavioral variant FTD, which often causes a lot of distress for family members. People present primarily with changes in behavior and personality. And oftentimes their cognition, their memory in particular, is quite good. So they remember everything. The problem is they lose empathy. So they don't care. They have apathy. They don't want to do anything. They're perfectly content to sit and do not much of anything. And oftentimes the most troubling thing is they will have inappropriate behavior. They may make sexual comments that make people uncomfortable. They may have, a temper where they never had one before. And sometimes they can get very angry very quickly. And it's, very distressing for their loved ones because unlike someone with Alzheimer's where they're clearly confused, these people don't seem confused, but they just seem like they become jerks kind of. And sometimes people have gotten divorced and all kinds of stuff before they really realize that, oh, there's something going on here. And so, but there is, the other thing is oftentimes these people will get diagnosed maybe around 60 or 62 with bipolar disorder. These are people that never have had bipolar disorder in their lives. True bipolar disorder is, presents in your 20s, sometimes your early 30s, but there's a lifelong tendency for alternating between depression and either hypomania or mania. But if you've never had that and all of a sudden you have it at 62, it's not bipolar disorder, it's FTD. And over time will declare itself more clearly. But, I can't tell you how many times over the years I've seen this. Um, so typically the frontotemporal dementias present younger than Alzheimer's, average in the 50s, sometimes in the, 60s, usually the early 60s compared to, 70s or 80s. That would be unusual to have the first symptoms. Um, about 30 to 40% do have a family history of FTD, and there are some associations with chromosome 17 in some people. Again, there's relative preservation of memory. Some people do have motor changes because the frontal lobe is where the motor cortex is. They might have jerkier or less coordinated movements. From a pathologic standpoint, it often involves tau protein, but not necessarily the same p-tau 217 and 181, pardon me, that are associated with Alzheimer's. FDG PET shows less activity in the frontal lobes. There are no current FDA-approved treatments at the moment, unfortunately, and it can be really tough for people to be told, well, you just got to live with this. And we do try to treat with some of the Alzheimer, the Alzheimer's drugs like the cholinesterase inhibitors, just in case they might help. And we really just kind of target specific behaviors. And it's a lot of education for family members in terms of how to handle some of these behaviors. Parkinson's disease, I mentioned earlier Lewy body dementia. Parkinson's disease dementia is also associated with Lewy body disease. Sorry, the development of Lewy bodies in the brain. It's just that Parkinson's Lewy bodies are held in the basal ganglia and don't spread everywhere, whereas in Lewy body disease, they're kind of spread throughout. Parkinson's is a motor disorder. It affects, it causes tremor, it causes slow movements, but it doesn't affect memory until much later. So typically, people will have Parkinson's and motor symptoms from Parkinson's for 5, 8, 10 years before they ever have any cognitive issues. So if someone has Parkinsonism and develops dementia in a short period of time, often that's Lewy body disease. If people have a long-standing history of Parkinson's and then start to develop cognitive issues, that is more likely Parkinson's disease dementia. This is a subcortical type of dementia that really is associated with executive dysfunction, difficulty kind of following directions, planning things. Memory per se is relatively preserved, at least until much later. It is more common in patients with Parkinson's who are older at the age of onset of their PD, who have had PD for a long period of time or have a rigid akinetic type of Parkinson's. People who are young, for example, Michael J. Fox, and people who have a tremor as a presenting symptom. The tremor in Parkinson's is kind of like a slow, they call it a pill rolling tremor. It's not a fast tremor like that when you're anxious or had too much caffeine. It's kind of a slow tremor like this. So people who develop the tremor as a presenting symptom and people who are young often don't develop dementia, or if they do, it's many, many, many years later. There are a subset of what we call Parkinson's plus syndromes. These are kind of relatively rare things that, statistically are relatively uncommon, but occasionally appear. PSP, or progressive supranuclear palsy, is a Parkinsonian syndrome where people will present with a lot of complaints of falling backwards. And when you examine them, when you have them follow a pen with their eyes, their eyes can't move up and down. Side to side, it's fine, but then they won't, like they'll move their whole head, but their eyes won't change. That is the key diagnostic feature of PSP. If any of you remember the actor Dudley Moore, that's what he had, and passed away from. And then there's these other, corticobasal degeneration, multisystem atrophy. These are things that really, frankly, I don't see that much because they are presenting more with motor symptoms or physical symptoms like dystonias, or, in the case of MSA, they have really crazy blood pressure management problems and urinary issues, all of which are because there's autonomic nervous system dysfunction. But these are people that end up being seen by the movement disorder clinic or regular neurology and are not having significant cognitive issues in comparison to their motor symptoms. So we see them less in our memory clinic. And then finally, hippocampal sclerosis or late is something that's, not commonly thought of or known in the general community, but actually accounts for a good number of people with dementia in the old people in their 80s and 90s. Has very similar symptoms to Alzheimer's. It just progresses sort of inching along kind of year by year, very slowly. So when we see people, who are 85 and look like they have Alzheimer's, but then all of their blood biomarker and other tests come back negative, then it's late. And late stands for limbic associated TDP-43 encephalopathy. It's a mouthful. It's not on the quiz. But just so that is often the default diagnosis when Alzheimer's is not present and we've kind of ruled everything else out. Currently, there are not blood biomarkers or other biomarkers that we can test for it, and it can only be seen at autopsy. But, just like with Alzheimer's, when I started out, that was how we could see it. We're hopeful that in the coming years, we'll have biomarkers for this as well. Transitioning into just a few of the treatable causes of dementia, normal pressure hydrocephalus. People will often present, they have large ventricles on an MRI, although many people with Alzheimer's and other types of dementia have large ventricles. Those people have shrinking of the brain from the outside in as well as the inside out. And so oftentimes their large ventricles are a result of what's called central atrophy because the brain is shrinking. However, with hydrocephalus, there's enlargement of the ventricles without a concomitant shrinking on the outside of the brain, and therefore there's pressure, there's not pressure because it's normal pressure, but there's enlargement of the ventricles that are compressing brain tissue without increasing the actual pressure in the brain. And because of the location of the ventricles and the areas they press on, it can cause dementia, ataxia. So usually they have a wide-based kind of staggering gait, almost like they're drunk. And then urinary incontinence. And all of these three things occur at the same time and appear at the same time. There are many, many people who come to my office who have dementia, who have problems walking, and who have urinary issues, all from different reasons. They may have gait problems because they've had lumbar spine surgery, or they may have urinary incontinence because of prostate problems. Just because you have all three of those things doesn't mean you have NPH. But, when people present with all of those at the same time without real other reasons for it, hydrocephalus is definitely worth looking into, and it is treatable with the insertion of a shunt. So a neurosurgeon will put in a little cannula. They, goes into the ventricle. It gets wired down through the neck and kind of down into the chest and empties into the abdomen. And so you're just constantly draining off CSF and putting it into your belly. Obviously slowly, but the shunt, as long as the shunt takes that fluid out, then you're not getting that buildup of fluid and compression of the brain tissue. And oftentimes they will determine whether someone is a good candidate for a shunt by doing a spinal tap first. If they do a large volume spinal tap and take out a certain amount of fluid and their symptoms improve, they can walk better or whatever, that means that they seem to be a good candidate for this type of treatment and will proceed with a shunt. Another thing that's very important to talk about and very treatable is depression. So depression in the elderly can present with a lot of overlap of symptoms of dementia. So it's really important to tease out whether, if somebody is presenting with poor memory, maybe loss of interest, you're not sure if it's apathy or depression, they're less active, they might be either kind of, have psychomotor retardation where they're just sort of sitting and not moving much, or they might be agitated and kind of irritable and kind of moving around and, rearranging things. They might, oh, I don't need to shower today, I didn't do anything. They might have sleep disturbances, appetite problems, either eating too much or too little. And they can have psychotic symptoms. All of these can appear in dementia, but the key is really understanding whether they have depression as a driver of these. So it used to be, called pseudo dementia, but that term has kind of fallen out of favor. But in the older population, people will, with significant major depression, may even present as though they are demented. And by treating the underlying depression, you can actually get significant improvement. So people with this sort of pseudo dementia from depression will often exhibit preserved orientation. Usually they answer, on every question you ask them, I don't know. What month is it? I don't know. But if you really push them, they know. Whereas when you have dementia, they really don't know. And they'll usually, if someone with dementia without depression, if you say what month it is, they'll be like, oh, May, like, no, it's November. But, they'll just say something. Usually if every answer is, I don't know, then there's usually a depression piece related. They will often have poor short-term memory and poor recall, but relatively good recognition. So if you give them a word list of 5 words and then come back to it later, they'll say they don't remember anything. And then, but you say, well, was, flower on the list? I'm like, oh yeah, and they get that. So it got in there, but then it just sort of, they don't have the energy to pull it back up. Whereas with Alzheimer's, it's like, didn't get in the first place. And, the important point here is that their cognition and their quote unquote dementia can improve dramatically if you treat the underlying depression. The only thing of significant concern is that a fair number of people with pseudo dementia will go on to develop a true dementia within about 3 years. So, it's important to kind of follow those people and be proactive in terms of monitoring cognition, because it can be a red flag for the appearance of dementia later. So I guess this is a good time to break and maybe answer a few questions. Robert, if you want to throw a few, because then we're going to just take a minute break if you want to get up and stretch or whatever in a moment, and then transition to talking about communication strategies. But if there are specific questions about this content, maybe I can take care of them now before we go into the next section.
Yeah, there are just a couple. I do see one question that says, does Medicare Advantage or do Medicare Advantage plans generally pay for diagnostic scans, MRI?
Most of the time, yes, and they're getting better. Sometimes we have to do a prior auth or, fill out some extra paperwork, but for the most part, we are. So here's the thing. For a long time, the answer was no, especially with Medicare. And what CMS does, most of the other plans will follow. But because now we have these amyloid removing therapies that are FDA approved, you have to do the diagnostic workup in order to qualify for these treatments. So therefore, they are paying for them because there is now treatment available. When there was not disease modifying therapy, they felt it was unnecessary and quote unquote experimental to do an amyloid PET, because what were you going to do with that information? Like, okay, yeah, it's up there. But now that we can take it out, the insurance companies have gotten much better about paying for these things. Any
Sorry,
other?
I have one other question from the same individual. What is the name of the biomarker lab test that is used?
Oh, I mentioned that earlier. It's the p-tau 217 to amyloid beta 42 ratio. That's the FDA approved diagnostic test. And then the other, we can look at the amyloid ratio. We can look at p-tau 217 by itself. We can look at p-tau 181 by itself. Um, and positivity across the board in those is very supportive of Alzheimer's, although not diagnostic.
Perfect. I have one question that says and I'm paraphrasing, I'm not sure I understand the question, but looks like the individual is asking that if there is any pharmacological or environmental help for late onset Alzheimer's. The same person also asked, once the cells are affected, is the damage permanent to the specific cells? Other cells, pathways compensate for the loss. So
So yeah, I mean, once the damage is done, it's done. And this is a progressive neurologic disease, so it will continue to degenerate if we know specifically with Alzheimer's disease. Um, there are, for people that are in a later stage of Alzheimer's, these monoclonal antibody therapies are not indicated or available. And we really just have these symptomatic treatments like, Aricept and Namenda to try to help symptomatically. And then the other piece is treating the behavioral issues and other, you know, related symptoms that appear. That's all we really have, but there's not any formal treatment that will modify the disease in later stages. I did see a couple of questions pop up in my vision here, so let me address those if I remember them correctly. The one just immediately was about the oxybutynin. Oxybutynin is a bladder medicine that is very anticholinergic and works opposite to things like Aricept and Exelon. There are many other bladder medicines that are anticholinergic, but they are targeted towards the receptors in the bladder or more specific areas, whereas oxybutynin is very anticholinergic all through the central nervous system and therefore can cause symptoms that mimic dementia. There was also a question about genetic testing. Can you read me that one? Because I couldn't see the whole thing.
yes. Is there a way to test for the gene discussed at the beginning for a person whose parents has Alzheimer's to find out if they will develop the disease?
So if your parent had early onset Alzheimer's disease, okay, so that's very different. The 5% of early onset, if your parent had it at 47 or 53, there are 3 mutations that can be tested for. These are the presenilin genes and the amyloid precursor protein. Those are 3 known mutations to cause early onset. And so if your parent had that and you're concerned about yourself, that's what you would get tested for. However, you would have to go through some genetic counseling to have it. If your parent had it at 73 or 85 or even, 65, those genes are not present. That's not what we're talking about here. You can get your ApoE genotyping done. You can get it through 23andMe. When they do the health testing and for late onset, that's what they're looking at. They're looking at your ApoE genotype. But like I said earlier, if even if you inherited an E4 gene from both of your parents, so you're E4, that does not mean you're going to get Alzheimer's. It means your risk is higher. And if you do get it, you might progress a little more rapidly, but you can have E4, and die of old age with no Alzheimer's. So it's important to understand that unlike the early onset mutations, which cause the disease, the E4 gene does not cause it, it just increases risk. And there's a lot of things you can do in midlife. So one reason to do it in midlife is to know your status and know how aggressive maybe you want to be in terms of lifestyle changes. If you're 46 and you're E4, you might be more likely to get on the treadmill after work and eat more of a balanced diet and just be more active overall, because that's where you're going to make, if you have high blood pressure, taking your medicine and make sure you keep your blood pressure down. If you have diabetes, keeping your sugars, your A1C down, below 6, whatever it is, those are changes you can do in midlife to decrease your risk later if you carry E4. But again, having E4 does not mean that you're going to get Alzheimer's. It just means that your risk is higher. Does that make sense? Okay. So now we're going to transition to the communication strategies and techniques, which I'm sure will be more relevant to many of you than the previous stuff that I talked about. Because, the fact is that regardless of the underlying cause of dementia, there are specific needs that these people have and specific ways to communicate with them to be more successful, in terms of both, having a good interaction, decreasing agitation, and, understanding that being respectful of their experience as a person, but also, not wanting to cause them more distress than they may already be in. Sorry, my arrow is not responding at the moment. Let me see. Okay. So it's really important to remember that people with dementia cannot help their behavior. With occasional exception, most of the time their behaviors are a result of brain cell death in specific areas. They, may be feeling confused or angry or scared. They may be aware that they're having trouble, but maybe completely unaware of the extent of their cognitive decline. I frequently I saw a lady yesterday who came in and she's like, oh, I have a terrible time with names. That was her complaint. Well, this lady has way more than that. She mixes up her kids. She thinks one of her sons is her husband. She, you know, doesn't remember really, she thought we were in Indiana, so in her mind, she's way back. So she had no awareness of the extent of her decline, but, did at least admit that there were some issues. Additionally, people may experience things like hallucinations or delusions or paranoia. So they perceive things incorrectly or say things they don't make sense. And in a situation, they might get angry and the more you try to reorient them to reality, the angrier they may get. I actually, again, yesterday, a different patient had a very long talk with her husband because his way of handling things, her problem is she wakes up at 3 a.m. and wants to go outside and rake the leaves. And he, gets in these screaming matches with her. It's the middle of the night. You can't go outside, blah, 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 and every night it's a fight. Sometimes she grabs his arms and he's on blood thinners, so he has bruises. But yet he does not respond to the fact, he's very set on reorienting her, that, I'm trying to make her understand that it's the middle of the night. And so, my goal is trying to make him understand that that's not going to work, and so the daughter is like nodding enthusiastically because we've had this conversation at least twice before. that's not going to work. So let's talk about some ways where you can handle this and maybe have some more success. So, it's just the perfect example of, you know, the fact that he has to enter her reality rather than him expecting her to be able to come back to this reality. So, effective communication with someone with dementia is a key to making sure, reducing behavior issues, ensuring their comfort and safety, and not exacerbating their agitation, which this husband was clearly doing yesterday. So some of the key strategies that we'll go over is one, don't make assumptions. Another big one that we'll spend some time on is joining their reality, focusing on the positive, and also remembering that nonverbal communication is equally as important to what is said. So again, don't make assumptions. Somebody with Alzheimer's may look fine. Their superficial social interaction may be totally intact. And it's always so frustrating for caregivers when somebody spends 5 minutes having a superficial conversation about, oh, where'd you grow up? And the person tells them, and, oh, he seems fine to me. It's like, okay, well, ask him to take out the trash or, you know, ask him what he had for breakfast. So it's very easy to assume someone with mild dementia, especially, may be fine. Oh, he seems great. They're not great. So, it's important to understand that they may still have good social skills. They may be able to make small talk with no problem, but ultimately there is a problem underlying. Had this issue yesterday with a different patient. A person with Alzheimer's is often not a good source of medical information, history, or symptom reporting. So I had one of my patients yesterday was going in for VA benefits that he deserves. He served our country, but typically has not been in the VA system. And, they found his DD 214 and we're getting him all set up for VA benefits and also pursuing some service connection because he was, dealing with bombs and things and has had some hearing loss and ringing in his ears. And whoever was interviewing him at that moment, was like, do you have ringing in your ears? He's like, not right now, but so he was denied, although he's complained about ringing in his ears, for years and years, at that particular moment, he's not a reliable informant because he was answering the question of right now, I don't have it in this moment. I had it this morning when I got out of bed, and so it's important to remember that someone with Alzheimer's is often not a good source of information or symptom reporting. I see frequently people will, that I send for social services and other things might get denied because, somebody didn't ask their loved one key questions, and the patient themselves may be, we call it anosognosia, lack of awareness of your own deficits. So, oh, there's nothing wrong with me. I'm fine. Oh, I can cook. I drive to Publix. I'm working. They haven't worked in 25 years and, they haven't gone grocery shopping independently in 3 years and whatever. But so if you only get that information from a patient, it's not a good source. So you have to get collateral information from a loved one. And then don't assume everything they tell you is correct. So joining their reality is probably one of the biggest things that it's hard for people to do, especially when you're close with the person. But it's worth spending a little bit of time on because it's one of the keys to successful communication and reducing behavioral issues. So, do not correct them, do not quiz them, do not use logic and expect them to understand and agree. Just like this lady was not going to be like, you would think, oh, it's the middle of the night, it's dark out, or, oh, it's raining, I shouldn't go outside and rake the leaves. Well, that's not going to work for her because in her mind, it's time. And in her mind, it's something she needs to do. Um, I also do have some, caregivers that tend to quiz their loved ones, every day they, what day is it? What's your name? What are our kids' names? What, and while a small percentage of patients like this and feel like it helps them stay on top of things, most of them don't like it. It makes them upset. It makes them anxious. It confronts them with their deficits. And, it's almost like torture. So, we really try to encourage caregivers to stay away from that, just because it doesn't really help anything. If there's something you want them to know, use a dry erase board, put the date on it. Today is, Thursday, November 20th. You have an appointment at 10:30 a.m. with Dr. Smith, and just have that, let that be their sort of orientation. But by quizzing them and, constantly making them feel bad that they can't remember things, you actually foster behavior issues and depression. Validate their reality. Um, if they say we're in Texas, okay, unless it's something that's dangerous, that there's, we encourage people to pick their battles. Don't fight over something that's not important, and it doesn't matter if it's incorrect. You know, um, don't embarrass them if they're talking in a group and they're like, oh, well, I'm the CEO of this company and I do this and that. And, maybe they were, but they retired 25 years ago. Just nod and go along with it, or you could potentially later be like, oh, well, he was, but he retired. But, don't directly challenge them and embarrass them in front of others. Um, and rather than trying to convince them that you're right, just join their reality. And I'll give more specific examples in a minute. Answer repetitive questions with the same answer every time. It can be super annoying. I hear people say, on the way here, they asked me 6 times where we were going. It's like, well, then just answer 6 times. We're going to see Dr. Smith at the Bird Institute. Because to them, each time it's the first time. Um, you know, they're not asking to annoy you. They're not asking to, occasionally people will ask repeated questions like out of anxiety or like obsessive impulsive need to like check on something, and they know the answer but they're just sort of confirming. But most of the time they um they I'll answer that question in a minute. But most of the time they, for them it's the first time they're asking, so you answer it like the first time. With regard to the lady going out in the middle of the night, she's very unsteady on her feet. She, lives in a very rural area where there's a lot of nocturnal animals and things. And so in her case, no, you're right. Why not let her go outside? What's the big deal? But in her case, it's actually not a great idea because of the number of things that could go wrong. Um, so, there are some times where you could just be like, okay, whatever, let her. But she might wander off. She might, there's a variety of reasons in her case where it's not the best idea. Um, so here are just some, examples of quote joining their reality. So you see someone with Alzheimer's that you've seen many times. Let's say they're your client. You've been to their house 12 times and you're their caseworker. And they say, oh, it's nice to meet you. Don't be like, oh, well, we met before. That makes them feel bad. You can just say, it's nice to meet you. I'm so and so. Every time. It doesn't matter. It's not the biggest deal. Reminding them that I see all the time. They come, oh, what a lovely office. I haven't been here before. It's like, here's a picture of you here in my office, because we take photos of all of our patients when they come for the first time. Like, I don't do that. I don't be like, oh, you were here 6 months ago. I just brush it off and go about the day, the visit, like, it's the first time. And there's nothing to be gained by making them feel bad that they forgot that they were here. Um, Here's another example. So the person has a daughter in New York. And when you see them, they say, "Oh, I just had the nicest visit with my daughter." You know, there's no point in pointing out that they didn't actually see their daughter or that the daughter didn't call. You just say, "Oh, I'm so glad." And then you move on. There's no point in convincing them because it'll just make them upset. And there's, you know, 100 different versions of this. They might be accusatory. They might say, "You took my keys." Don't say, "I didn't take your keys. Why would I take your keys?" You say, "I see you're upset because you can't find your keys. Let's start looking for them. Let me help you find them." So, trying to redirect it to something more positive and joining their reality. Your keys are missing, probably because you hid them somewhere, but, I didn't take them. Um, that doesn't help. So let me help you find them. That, and again, this also kind of reframes it in terms of a more positive way, which is another strategy that we'll touch on. A lot of these kind of meld together. Um, and there are times when you really should not give an actual answer because it could trigger a negative reaction, particularly when someone keeps asking about a loved one who's deceased. When you have an 87-year-old who's asking, "Oh, I have to go see my mother. My mother's coming over. My mother this." Well, their mothers, died 25 years ago. Um, if you tell this person who needs to go see their mother that their mother's dead, they may grieve. They may react like it's the first time they're hearing this. And so you can trigger a very catastrophic type of reaction um, by telling them the truth. Now, let's say their mother is buried in Indiana. You can say, "Oh, well, she's in Indiana, but maybe we can get in touch with her later." So you're entering their reality. You're providing some truth up in there because she technically is in Indiana. She's just buried, but you don't have to point that out to the patient. She's like, "Oh, she called, she's running late," or, "She's in Indiana, but we'll try to get in touch with her later." Those are things where you're entering their reality, you're confirming their feelings, but you're not providing conflicting information that's going to make them upset. Um, they might repeatedly ask where their car is. This comes up a lot, especially with men. It's always the men that want to still drive. But they stopped driving 3 years ago and they get mad every time you tell them that. So, rather than telling them that they can't drive, just be like, "Oh, the car's in the shop." You know, they don't need to know that you sold it or that, you gave it to their grandson. Um, but you can say, "Oh, we lent it to Joey. He needed to run some errands today." Um, and that will kind of get them off the topic in that moment. And chances are they won't remember it later and you'll have that same conversation again, but at least you'll kind of find the therapeutic fib that works. So that's what it's called. You're not lying. Lying implies sort of malintent. Um, Therapeutic fibbing is you're not telling the truth, but it's because you're trying to protect them and you're trying to de-escalate and not make them upset. So, people oftentimes have a hard time kind of coming to terms with this because especially when they're dealing with a parent, "I don't want to lie to my mom. I don't want to lie to my husband." And so getting used to the fact that you're utilizing a therapeutic technique rather than maliciously telling a lie can really kind of help people digest that better and um, get used to doing it. Sometimes it can be be very hard, especially on the fly, um, because they may say something that you weren't expecting, and then you have to kind of figure out in that moment, especially when emotions are high, um, how to handle it. But at the end of the day, practicing that and maybe even coming up with some potential answers in advance, can be useful when the situation does come up. Um, yeah, I see the example there. The car is stolen. Well, because it's not there because you're not allowed to drive it anymore, and that can be really hard. So the car is stolen. Well, I've put in a police report. They're looking for the car, So you have to just kind of work with whatever framework they're giving you and give them something that is reasonable that they will accept to move on to the next topic. And, even if they don't fully let it go, they'll let it go in that moment. You may have the same conversation 6 times tomorrow, but right in that moment, you can like, oh, well, that's a relief. Thank you for calling the police. Um, so in terms of focusing on the positive, again, try not to remind them of their deficits. Um, Focus on skills and memories they still have. Some people can still bake, can still do woodworking, can still make art, so try to encourage them to engage in those activities or talk about them. Again, with joining their reality, we talked about some negative examples, but some people may hallucinate little girls over at a table having tea and it's causing no distress, and that, but they want to talk. So tell me about the girls, what are their names? What are they eating? What do they like? Or, they're not upset because some people, are definitely convinced that they're still working and, they're 25 and whatever. Oh, tell me about your job. What do you do? So unless they're like, I have to call into work, tell them I'm going to be late, unless they're upset about something, you don't have to worry about that piece, but just have them talk about their reality. You know, we're in Indiana. Oh, tell me where you grew up in Indiana. Tell me what school did you go to? And, they may or may not be able to answer, tell me about your friends. And they can get on a topic that makes them comfortable. And it doesn't matter if it's correct because for them, it's pleasant and it's bringing them happy memories. So there's no reason not to engage in that conversation. Um, so all of this, again, is to create success and not frustration, to avoid increasing agitation, and try adapting the conversation to what they can understand. It's also important to remember that nonverbal communication can be super important. Make eye contact, but don't be threatening. If your posture is such that you're standing over someone, or your tone of voice is aggressive, they may misinterpret that. So use sort of gentler tone, make sure you make eye contact, use sort of therapeutic touch, soft touch if somebody's open to that, but don't touch someone who clearly doesn't want to be touched. If you look very serious or very tired, that can be perceived as you being angry or you being impatient. Standing over them can be perceived as threatening. So if you smile, speak softly, make eye contact, and get on the same level as them, you may have more success. If someone's in a wheelchair, kind of slumped, and you're standing above them, kind of kneel down and talk to them more face to face, and that can make them feel more comfortable. Another thing is, slow down. We tend to talk quickly. Um, People with dementia often are slower to process things. And if you ask them a question and they don't answer, and then you ask another question, they're still working on that first question. It's a reason why people tend to withdraw some in bigger social groups because they can't follow everything. So ask them a question, give them time to answer, repeat the question, and then maybe you'll actually get a successful answer. We often will just be like, get impatient and be like, okay, I have another patient in 15 minutes, I got to go. And then, you don't give them the time that they need where they could be more successful. Keep sentences short and simple. Ask, if you ask someone a long question, or if you give them, I hear this all the time from caregivers, like, Hey, go out in the garage, put this in the green bin, and then take it out to the curb. That's three things. They can't remember three things. They'll walk out into the garage and be like, why did I come in here? So you have to do step by step, one by one. Same thing with asking questions and, keeping sentences short and simple, because when it gets too far, they're lost. It's important to reduce background noise and distractions. If you're going into someone's home, turn off the television so that they can fully engage with you. Avoid open-ended questions, especially if their dementia is more advanced. Ask more yes or no questions, although you can't assume those are always correct. Are you in pain? Is anything bothering you? Things where it can be more simple for them to answer. If you need to give them choices, don't say, what do you want for lunch? All of a sudden, every food in the world is a possibility. Do you want a turkey sandwich or a burger? Two options. So they can just pick one, because once you get to three options, then that's a lot. Once you're looking at a menu and there's 30 things, that's too much. So, if you're with someone, you can say, you know what they like. You look at the menu and say, you want the tuna salad or the Caesar, and then they can answer that. So you have more success. Um, Another thing is, don't ask someone if they want to do something, because inevitably the answer is no. Do you want to go for a walk? Do you want to go for a ride in the car? Do you want to go to the doctor? No. Okay, you tell them, put on your shoes, we're going for a walk. Here's your clothes, it's time to get dressed. So especially when someone has a lot of apathy and is sort of content not to do much of anything, they will avoid activity. So if you really need them to do something, it's time for your shower, or the water's on, let's get in the shower. Not, do you want to take a shower? Because the answer is no. I don't want to get wet. I don't want to get cold. I don't want to go take off these comfy clothes that I'm in. So it's time to. You will often have more success just with that simple, people will naturally want to be respectful. Like, do you want to do this? Because that's a respectful way to ask someone. But when someone can't make those proper decisions for their own on their own, you know, like, do you want to take your pills? No. Here's your pills. Here's a glass of water. Limit commands to one step at a time. If they really give you a hard time and it's something that you got to do, like that they've maybe have a wet diaper and you need to change it, come back in 15 minutes and maybe it's like it never happened, and they'll, and maybe change the way you phrase how you approach it, and you might have more success. So, people often make the mistake of getting more and more agitated. Like, we really got to do this. I need you to do this, So if you know that your loved one is going to give you a hard time about getting dressed for an appointment or whatever, give yourself an hour extra. Start way early so that if you know they're going to give you a hard time, you can have that buffer built in to come back and give them a few shots before you really have to kind of put your foot down. And you can also use leading questions. Like, if you really want them to take a walk, but they might be resistant, be like, oh, it's such a nice day for a walk, isn't it? And maybe they're like, oh, yes, it's beautiful. Let's go. So if you're, you're worried that they're not getting enough hydration. Oh, it's so hot. I would love a glass of water, wouldn't you? Oh, yeah, that sounds nice. But they're not going to take it upon themselves to go get water or think to do it themselves. So these are ways to kind of lead them and encourage them without being too direct. I feel like maybe I should have put this at the very beginning of this section, but some of the common behavioral issues that we see in dementia are things like anxiety. The vast majority of behavior problems in dementia are linked to anxiety. People are anxious because They don't know what they're supposed to be doing. They don't recognize their surroundings. They don't know who you are. They don't remember what they're supposed to be doing today. What was this? What was that? Where's this? Where did I put my that? So anxiety drives a lot of behavior, a lot of, rummaging. I'm looking for something because you can't remember where they put it, and then they don't remember what they're looking for. So anxiety is one of the biggest ones, and we often can successfully treat anxiety with antidepressants that also treat anxiety, things like Zoloft or Lexapro or whatever, because those are fairly benign in this population and can help a lot with decreasing that just baseline level of anxiety without causing issues like falls, etc. Sometimes there's a lot of sadness, particularly in people who are very aware of their deficits. Um, they can be sad and upset and sort of in the mourning of what could have been and what they've lost. Um, Alternatively, some people get very angry. And I have one patient who she's so mean. Every time I see her on my schedule, I just dread it because she's fully aware of what's happening to her and she's mad at the world about it. And, you know, it's so hard to engage with her. And, I really have to kind of give myself a pep talk, not to get kind of sucked into her state of mind and really stay neutral and, validate her feelings. I would be upset if I were you as well, but how can we, handle this? And then, of course, there's people that are just angry and don't realize what's going on with them. And people can get aggressive and agitated for any one of a number of reasons. Oftentimes people are uncooperative because I don't think they need to do the things that they need to do. I already took my medicines. I already took a shower. It's like, well, you haven't taken a shower since last Wednesday, but so they don't recognize that. So then they don't cooperate. People will often have delusions or false beliefs and hallucinations. Sometimes those are benign and you can let them go. And sometimes they're very severe. I have one lady that, showers in a bathing suit because the people have installed cameras to watch her. She's so paranoid. She makes her son try her food before she eats it to make sure it's not poisoned, etc. She had not been eating and lost some weight, but she's someone that we needed to treat with antipsychotics because she was at risk of self-harm through poor nutrition, etc., because her delusions were so profound. But again, if it's just false belief like living in the wrong state because you're living in the past mentally, or there's sweet little kids having a play date over there even though there's no one in the room, that's harmless. And if it's not causing them distress, there's no need to treat it. Shadowing, meaning like following you around everywhere you go, often like a dog might do. You can't go to the toilet by yourself without someone being there, or a toddler will often do this. So shadowing, following you around, people can get very annoyed with that, but you have to kind of understand, set boundaries, try to, calmly say, I'm going to the bathroom, I'll be back in a minute, distract them with their favorite music or whatever. Inappropriate behavior, wandering, these are all things that, can be dealt with in different ways. So in terms, if someone has some of these behavior issues and does require some de-escalation because they've gotten agitated, remember the communication strategies, enter their reality, don't correct, stay firm, but stay calm and don't act condescending, create space, give them a little room and privacy if they need it to, if you need to step away for a few minutes. Sometimes, somebody can be angrier than you've ever seen anyone, and you leave the room and come back and then it's like nothing happened and they have no recollection. It's like nothing ever happened. So sometimes that actually works, or they may remember they were upset but not what about, or maybe they'll even apologize, even though they don't quite remember what occurred. Um, Always provide reassurance and validation, try distractions. Pets are wonderful. Um, you know, Favorite TV shows, things that they love. If they're getting antsy or agitated, put on something, make them smile, and try again later with whatever you were trying to do. Or if you're trying to provide care, put on music while you're doing it so that they're maybe distracted and focusing on that. Um, you can also sort of use techniques like breathing in sync with them, using calming touches of their hand. There's a person in the resources that'll be listed in a couple of slides, Teepa Snow. She has a whole sort of caregiver information network out there with some techniques that work. And so these are just some resources. Our institute has something called the Alzheimer's Caregiver Podcast. It's on our website. It's also on Spotify and Apple. There's like 250 episodes. We have listeners in like 50 countries. It's crazy. Eileen Poyley, who's our director of education, does this podcast and sometimes has guests, sometimes not, but covers all kinds of topics, handling these behavior issues, helping your loved one find an assisted living facility, getting care at home, how to handle the holidays. There's all kinds of topics. And the nice thing about them is, unlike a support group or a workshop, which is at a specific time, this is something you can do on your own when it's convenient for you. Listen in the car or whatever. We have monthly workshops, and the dates and topics are on our website as well. Some other resources, the federal government has some great resources, both at the alzheimers.gov as well as the ADIR Center, which has a lot of printed materials that, publications that we use to educate caregivers. The Alzheimer's Association and the Alzheimer's Foundation of America both have a wealth of information on both the disease and various caregiver resources and techniques and support groups. I mentioned Teepa Snow and her positive approach to care technique. And then these are the primary references that I used for the talk. And so I will kick it back to Robert, and then, if there's any questions you want to cover, and then whatever you need to cover for wrapping up and reminding people about the CEUs, etc.
Thanks, Dr. Smith. I know I did see one question that I'll read here in just a moment, but I would like to say if you have a question that did not get answered, please feel free to retype it. Lots of messages come through, and sometimes we miss a question or two. And so I try to keep track of all the questions throughout today, but if we missed one, please feel free to retype it so we can address it. Dr. Smith, I did see somebody say, what are the statistics on gender and cultural cases of Alzheimer's dementia?
Sure. So as far as gender, it does affect women, about 1.3 women for every man. And it's not just a consequence of women statistically living longer. There are factors involved that we don't understand, but it does affect women slightly more than men. As far as other groups, Blacks and Hispanics are disproportionately affected. We don't fully know why, although some of it has to do with some of the vascular risk factors that are increased in those populations. That is an area where, we're striving in terms of research. I know this is a state talk, so I have to be careful about what I say, but, we do try to engage underrepresented groups in research because it affects them disproportionately, and they are often underrepresented in the clinical trials for the new treatments. And we want to make sure that these new things that we bring to market work in everybody, not just in the people who typically participate in trials.
Thank you. I did see a question that says, I have a client with diagnosed Lewy body dementia. As a mental health counselor, how can I best treat him within my scope of practice?
Well, the key really is, understanding that that person might have psychotic symptoms, might have hallucinations or see things and hear things that aren't really there. And so, the key is really understanding that, their reality is different and just, you know, obviously if they have psychotic symptoms that cause distress, that would need to fall under the, medication purview of a physician potentially. But within that, you can still be very supportive, if they have hallucinations and are seeing things that are not distressing or require medication treatment, explore them, talk about them, get them to kind of share their experience so that you can help support them.
Perfect. Thank you. And I have a question that's just a general question. I know in the state of Florida, there's been a lot of focus on working with seniors who may be in crisis. And so, do you have any insights or recommendations? Let's say we may have a lot of members of like a mobile response team on this webinar. What can they do if they approach a situation where somebody is maybe experiencing symptoms of dementia or Alzheimer's? How can they, work to address that individual's need in crisis while also being considerate and sensitive of their experience?
It's a great question. One of the key things is that a lot of times, the dementia piece often gets left out, like people will, again, make assumptions that they're fine because they're living alone or whatever. And it's, sometimes these types of crises are what brings the dementia diagnosis to the forefront. It's like, oh, well, the reason that this is all happening is because they have dementia and they have forgotten to take their medicines for, 6 months, and they have been eating, soup out of a can with a spoon without heating it up, and so it's really important to always consider that, statistically, if you're dealing with an older population, the likelihood of dementia can be high. And so, um, do a little bit of a cognitive evaluation without being too intrusive to really understand if that's part of the picture, because then the treatment approach is going to be different if it's, a mental illness thing versus, a confusion thing. And so you have to really approach that a little bit differently. Engage family members, try to find out if they have next of kin or loved ones. Maybe they've pushed people away, but the people that they've pushed away don't realize that that's because they have dementia. So you have to kind of investigate that to whatever extent you can using some of these tools. And the other thing I would say is don't also, the opposite. Don't assume that someone has dementia just because they're old, because that happens too. Um, I tell this story often. People ask me what got me into this field in the first place. And, I grew up with very healthy grandparents who were very active. They actually owned a nursing home. They were fun. They were people that I would choose to be friends with, at my age. And so, you know, there's this sort of misconception that people, when they're old, should be confused or whatever. And that's definitely not the case. And I was in medical school and I was assigned to an emergency room, and I was told to go interview some lady who came in with chest pain from an assisted living facility. So I went in and I talked to her. She told me she was eating the peach cobbler. She started to feel pain in her jaw and it went down, whatever. It was very clear. Um, and so then it was time for rounds and I was presenting the case, and the attending just started laughing at me. And I was like, what? And he's like, you went into the wrong room. The lady I'm talking about doesn't know anything. And I was like, actually, you're wrong. She just doesn't have her dentures because the, EMTs didn't bring them. They left them at the facility. So it was hard to understand her because she didn't have any teeth, but she knew perfectly well exactly what had happened. And so that really angered me, like how quick he was to brush her off and think she was confused just because she didn't have her dentures. And that really kind of set me on this path of, oh God, I need to go into, working with older people and protect them. And so, it's just as important not to assume that someone has dementia when they're old because maybe they don't. And so look at other factors that could be contributing to a picture that looks like that. So just a little asterisk on the end of things.
Oh, thank you so much. And it almost sounds like, especially when working with individuals where maybe there is a concern of dementia or Alzheimer's, and responding to those situations to be cognizant of what the family's needs are as well. I
Yeah.
think sometimes that can get overlooked, perhaps, and especially I think for our individuals that are responding to situations, kind of taking a holistic look at the entire situation.
Hmm. Absolutely.
Well, thank you so much. I think we got all the questions. I'm going to go ahead and take over and go through the conclusion. If anybody does have any questions, we do have Dr. Smith's email here. You can feel free to send her an email. Say, hey, I have a question, didn't get answered in the PowerPoint, or you can email our team and we'll get that answered for you. But Dr. Smith, I want to thank you so much for the time that you spent with us today. This was a really timely webinar. I think a lot of people are really interested in this topic. I think it affects a lot of us both personally and professionally. So thank you for all the information that you shared with us.
It's my pleasure. Thank you for having me.
Yeah. Well, thank you all for joining us. The evaluation will automatically populate when I end the webinar here in just a moment. You will also receive an email with the evaluation link in 24 hours. The evaluation will close next Tuesday, November 25th, 2025. If you have any questions, please feel free to email our team at training@floridabha.org and we'll be glad to assist. Certificates will now be emailed to the email address associated with your attendance within 30 business days. You will not need to sign into your FATA account. If you need CEUs reported, those will be reported to CE Broker within 30 business days. You must have attended the entire webinar and completed the evaluation. We are not permitted to provide partial credit. As a reminder, the recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording and PowerPoint, visit www.fata.org, navigate to the Resource Center, and click on Training Library as shown on the screen. Thank you everyone for participating in today's webinar. Thank you again to Dr. Smith. We'd also like to recognize and thank the Florida Department of Children and Families for funding today's education. Have a great day, everyone, and please hold for the evaluation.